Welcome to the University 15 Lecture Hall, where we break down complex medical topics into clear, actionable protocols for your exams and practice. I'm your host, Dr. Dinesh Kumar Pandey, bringing you this session on behalf of TV15 Education and the Institute of RA Delhi. Today, we are tackling a strict clinical challenge. Patient symptom reporting is only the first step. A formal diagnosis depends on reaching a specific quantitative threshold. That threshold is determined by the EULAR diagnostic criteria. A physician cannot officially classify a patient with RA unless their clinical presentation generates a specific, quantifiable mathematical score. Once we reach that score, we move immediately into a rigid pharmacological hierarchy. For medical exams and clinical practice, you must be able to categorize the distinct tiers of conventional and biological DMARDs. This session is an exercise in clinical first principles. First, we will run the EULAR math to verify the condition exists. Only then will we outline the exact pharmacological arsenal required to manage it. Let's move to the digital board and break down the exact EULAR scoring table. This chart displays the parameters of the EULAR criteria. Category A focuses on joint involvement. The diagnostic math here is objective. The smaller the affected joint and the higher the quantity, the higher the severity score. Pain in a single large joint, like a shoulder or hip, results in a score of 0. But as the disease impacts smaller joints, such as the PIP, MCP, or wrist, the points begin to accumulate. This bottom row shows that if a patient has more than 10 affected joints, with at least one being a small joint, they reach the maximum weight for this category, a score of 5. To add another layer of evidence beyond physical symptoms, we look to Category B, serology. This section of the table outlines the scoring for two markers, rheumatoid factor, RF, and anti-citrulline protein antibody, ACPA. A negative result for both keeps the score at 0, while a low positive adds 2 points and a high positive adds 3 points. Joints and serology provide the majority of the data points for an RA diagnosis, but the picture is incomplete without measuring systemic inflammation and duration. This chart introduces the final two categories, Category C for acute phase reactants and Category D for duration of symptoms. This row displays the scoring for C-reactive protein and erythrocyte sedimentation rate. If either the CRP or ESR levels are abnormal, it indicates systemic inflammation and adds 1 point to the total. The final point is determined by a time threshold. To satisfy Category D, the patient's symptoms must have persisted for at least 6 continuous months. With these variables accounted for, we calculate the sum total of Categories A through D to reach a final number. This final section of the board confirms the clinical protocol. A sum total of 6 or higher fulfills the definitive diagnosis for RA. This mathematical requirement ensures that aggressive, immune-modulating therapies are only deployed when clinical data satisfies the minimum threshold. Once a score of 6 or higher is confirmed, we move to the standard pharmacological protocol. This list displays the conventional disease-modifying anti-rheumatic drugs, DMARDs, that form the baseline of treatment. To aid in recall for exams, we use the mnemonic Cute and Pagli Malika Sharawat. We map the first 6 letters as follows: C for hydroxychloroquine, P for penicillamine, A for azathioprine, G for gold salts, L for leflunomide, and I for JAK inhibitors like baricitinib. The remainder of the mnemonic identifies M for methotrexate and S for sulfasalazine. While you must know the entire list, one drug in this category serves as the cornerstone for clinical management. Methotrexate functions as the first-line drug of choice, establishing the baseline against which all subsequent biologics are measured. What happens when conventional therapies fail to suppress disease progression? This section introduces biological DMARDs, which are targeted therapies produced through recombinant DNA technology. There is a critical prescribing requirement here. Biologicals are administered in combination with methotrexate to prevent the patient's immune system from neutralizing the drug. This list identifies the TNF-alpha inhibitors. For these, we use the mnemonic ACE inhibitors cogolimaro. Mapping the letters gives us adalimumab, certolizumab, etanercept, infliximab, and golimumab. This lower section includes remaining options, such as IL-6 inhibitors, co-stimulation blockers like abatacept, and B-cell deplemers such as rituximab. The escalation protocol follows a clear path. Establish a baseline with methotrexate and only introduce targeted biologicals if the disease remains active. As this diagram illustrates, RA management is a direct pipeline from mathematical diagnostic data to a structured medical response. A combined score across joints, serology, reactants, and duration provides the empirical proof required to initiate a DMARD regimen. By utilizing the mnemonics for conventional and biological DMARDs, you can accurately categorize the treatment options available once that diagnostic threshold is met. I'm Dr. Dinesh Kumar Pandey. This session has been presented by TV15 Education in association with the Institute of RA Delhi. By linking specific diagnostic criteria to a tiered pharmacological hierarchy, clinical practitioners transform rheumatoid arthritis from a subjective complaint into a manageable clinical protocol.